Welcome, everybody, and I would like to welcome our panelists in a very special way. We currently have Daisy Mayo, who is a psychologist, bipolar disorder, will give us a bipolar disorder overview. I also have Osir. They will introduce themselves when their time comes. And then there is Dr. Nyamute Linda, who is running a little bit late because of work. But she'll join us in due course. Why are we interested in this topic? Is because mental health is becoming a key area of focus, especially within the non-communicable diseases space, where we see mental health as a key element of what we do as an institution, and an area that requires very targeted efforts, very deliberate interventions, and very, very intentional, because over time we've neglected this condition, and yet many of our family members, our communities, our workers, our workmates, even ourselves, at one point or another, we are affected by mental health issues. We've run a series of these mental health webinars. The first one we did on a lived experience. The second one, we looked at women plus 50 years plus, where we were basically discussing what changes in a woman when she gets to 50 plus, what are some of the challenges, and what are some of the coping strategies. Today, this is the Bipolar Disorder Week. We are working together with our partners to shine a light on this very neglected area of work. When we were growing up, we didn't understand bipolar. We may have punished our children because they were not behaving in a particular way, because we did not know what they were going through. So this awareness week, we are really trying to let parents know, let people know, let colleagues know about bipolar. It's a condition that can be managed. It's a condition that can be, we can help people around us cope with it, and to have a meaningful life. So we have brought on board specialists in this area, but we have one gentleman who has lived with this condition, who is coping with this condition, and we'll be listening to him so that he can also share his own experiences. So we'll have three panelists. They each have a short time to talk about, to address specific elements of our conversation today. I'll be your moderator. My name is Mary Amuyunzu Nyamongo. I'm the current chair of the NCD Alliance of Kenya. I'm also a technical advisor to the African Institute for Health and Development. I am a mental health advocate in this country, and I'm trying to my level best to ensure that we put it at the political agenda. I want to welcome Daisy Mayo. If you can introduce yourself and then make a brief presentation focusing on why the NTD Bipolar Week and what is really bipolar. So we could welcome, so that we can also have our members listen. For the participants, there's a Q&A window. Please use it to communicate, to ask questions, and our participants and our panelists will be looking at this this window and responding to your questions. Please pose your questions there, and we shall keep an eye on that window so that we can also provide answers as we go along. Over to you, Daisy, and welcome.
Thank you, Dr. Mary. I hope I am clear enough, and my slides are visible from your side. Kindly confirm.
Yes, we can see them.
Thank you. So let me welcome you all for this webinar as we learn about bipolar. My name is Daisy Mayo. I am a clinical psychologist based in Baringo County, a mental health advocate, and I'm also the Secretary General for MPAC, which is the Medical Psychologists Association of Kenya, which is a professional body that advocates for mental health professionals, and we also aim to create awareness in the public to promote policy development and the welfare of mental health professionals in the country. So for today, we're going to talk about bipolar disorder, and this is just the overview of what we're going to learn today. So we have the introduction. We'll have a brief overview of World Bipolar Day and the events that we are planning to have in Kisumu to commemorate this day. We're going to learn about bipolar disorder, the burden of bipolar disorder in Kenya, and some of the psychological interventions for bipolar disorder. And I believe we'll have another panelist who will talk about the pharmacotherapy aspect of this disorder. So, World Bipolar Day, which is this day is observed every year on March 30th, and this day was set in honor of Vincent Van Gogh, who was diagnosed with bipolar disorder. He is a famous painter, and he's believed to have had this disorder. And the International Bipolar Foundation saw it fit to mark this day in order to raise awareness and to eradicate stigma associated with this illness. So for this year, we have a theme which is celebrating strength, amplifying voices, and driving change. So we want to celebrate the resilience that people living with bipolar disorder have showcased. We want to amplify their voices to ensure that we give them a platform to share their experiences. We also want to amplify our own voices to create awareness and to promote inclusivity. We also want to drive change, especially in terms of policies and interventions and community actions that aim to improve the mental well-being of people living with bipolar. So for this year, we have been having a week long of activities from 24th and 30th being a Sunday, we decided to mark this day on 29th, which is on Saturday. But we've been engaging with people with lived experience, caregivers of people with people living with bipolar disorder, and also mental health professionals in various activities such as webinars, this being one of them. We'll also have a radio talk show. We'll have mental health screening film, as well as assessments. And we'll also have awareness work. And for those who might need therapy sessions, I will also be conducting that, both before the event and also during the event, which is on Saturday. So let us look at what bipolar disorder is. As you can see, there's a simple illustration. There's an individual on a screen, and there's a happy face and there's a sad face. So this is just a simple illustration of what bipolar disorder looks like, but it is definitely more than this. It might seem as mood swings, but it's definitely more than this. And this illness affects the emotions of an individual, the energy levels, and the ability to function in the society. And there's not been an exact cause as to what causes bipolar, but there's an interplay of various factors between genes, neurobiological changes, and environmental factors. So let us get in depth on what bipolar disorder is. So from the name bipolar, it's a Latin word, two Latin words, bi and polar. Bi meaning two and polar meaning extreme opposites. So there are two sides. There's the mania or manic episode, and there's the depressive episode or depression. So on one end, one has elevated mood, euphoria, and increased energy. There's racing thoughts and impulsivity, decreased need for sleep, and excessive spending or risky behavior. On the other hand, it's quite the opposite. So one has persistent sadness, hopelessness, loss of interest in activities they used to enjoy. There's fatigue, changes in appetite to sleep, social withdrawal, and suicidal thoughts. This is another depiction these two sides, the manic episode and the depressive episode, where you can see a person is feeling like they're on top of the world, and on the other end, they feel like they're drowning. So there are different types of bipolar. There are three types. There's bipolar 1, bipolar 2, and bipolar 3, which is also known as cyclothymic. So for bipolar 1, based on the previous slide, we've learned about the manic and the depressive episode. So for bipolar 1, one exhibits a severe mania and severe depression. So just to refer back, one has this manic episode and a depressive episode. For bipolar 2, there's hypomania and depression. So one experiences a manic episode, but of a lesser degree. And they also have depressive episodes. When it comes to cyclothymic disorder or bipolar 3, one experiences all these symptoms to a mild degree, but it occurs over an extended period of at least 2 years. So those are the three types of bipolar. Let's look at the burden of bipolar disorder both in Africa and in Kenya. So definitely this disorder has impacted individuals, families, and even the healthcare system, both in Africa and in Kenya and even worldwide. But despite this burden, we find that in Africa and in Kenya, we have very few studies that have been done. And this calls for more research so that the data that we get informs how we manage this condition and the policies and in terms of resource allocation. So let's look at a study, a community survey that was done in Nigeria and Ethiopia by Esan and Asan. So from this, they found out that the prevalence of bipolar disorder in Africa ranges between 0.1 and 1.83. Okay, while this number might seem very low, when you look deeper, you find that there's 36.2% misdiagnosis, which is a very high figure. And they found out that bipolar disorder was often mistaken for schizophrenia and depression, which is something that mental health care professionals need to be very keen about to ensure they check proper history and ensure that they do not misdiagnose the individual, which will also affect the treatment and the overall outcomes in general. Something also that we need to be keen about is the comorbidities. The research found out that 60% of people with bipolar disorder have additional psychiatric and medical conditions. And most of the time we find that we often dismiss some of the complaints that our patients have. And looking at this figure, it means there's something we need to do about it to ensure that they're also taken care of in terms of other psychiatric and medical conditions, which might affect their illness, or their mental health illness might also affect the management of these comorbidities. So another important figure, the study found out that 8.1% of males and 5.4% of females reported to have attempted suicide, which is also high, but also somehow consistent with the figures that we usually have, where males are more likely to attempt suicide compared to females, but it is still a concern. So from this research, they found out that there are various challenges that need to be addressed, which is misdiagnosis. There's also stigma, which affects the health-seeking behavior of these individuals, so they might not go to hospital and be diagnosed, and this might explain the low number that we have. There's also limited mental health infrastructure, where some people don't know that these services are available, or in some areas they're actually not available, so you might not get the service that someone might require. So from this, they gave recommendations to have more research better diagnostic training and awareness campaigns, just to ensure that we try and manage bipolar disorder in Africa. So let us take a look closer home in Kenya. So still, we still had the same issues of less research being done in the country, but there's still a burden both to the healthcare system and even the economic implications that this illness has, and we'll look at that in a bit. So there was a study done in Bungoma County, sorry, and they found out that 78.2% meet the criteria for a mental disorder. These are mental disorders in general. So for bipolar disorder, they found the prevalence to be 13.8, which is a bit high, especially compared to the statistics that we had for the research done in Nigeria and Ethiopia. And some of the risk factors they identified was the male gender, the youth, low-income earners, and those living alone. And there's some of the challenges that they experienced. Stigma, underdiagnosis, limited funding, and infrastructure. So they recommended for more research on bipolar disorder, improved diagnostic training, more community mental health programs, and more funding and awareness campaigns. So let's take a look at the economic implications that this illness has. So there's the Kenya Mental Health Investment Case 2021, which is a document produced by the Ministry of Health just to shed light on bipolar disorder or the landscape of mental health disorders in the country. And it highlighted the economic implications that mental illnesses have, and more so bipolar disorder. And in general, mental illnesses account for 13% of Kenya's disease burden, which is high, and the economic cost is at 62.2 billion shillings annually, which accounts for 0.6% of our GDP, which is lost due to productivity. So with that, they recommended for the country to invest 32 billion for this period, 2021 to 2031. And from these investments, they predicted to have 7 billion gained in productivity, because the illness affects the productivity of an individual. So if the country invests 32 billion, they're going to get back 7 billion in 10 years. We are also going to regain 14,651 healthy life years. So while the return of investment is a bit low, which is 0.2 compared to spending 1 shilling, it is still important for the country to invest in managing bipolar disorder. And it is an opportunity for the country to also invest in early diagnosis and better treatment, just to improve the health of its citizenry and to improve economic productivity. So it might take time for the country to regain back what they had invested, but it is definitely something to look into, because despite the economic gains being low, you find that we have more healthy life years gained. The people living with bipolar disorder are more productive, and they're living a life that is of good quality. So with that being said, let us look at the psychological interventions that we try and employ for individuals with bipolar disorder. So first of all, it is important for the individuals and the families to understand what the illness is about, the implications that it will have, and the treatment that treatment interventions that they can employ to manage the illness. There is also cognitive behavioral therapy, which works to manage the negative thought patterns that people with bipolar disorder exhibit. There is also interpersonal and social rhythm therapy, which aims to stabilize routines. There's family focused therapy that enhances family communication, because most of the time you find that the interpersonal relationships of this individual are often affected. There's also mindfulness based therapy that aims to improve emotional regulation. There's peer support and psychosocial rehabilitation, um, such as group therapy, where we have support groups. There's also self-care and lifestyle changes, such as regular sleep, good diet, exercise, stress management, and maintaining a routine. So all these strategies, they play a very important role in the management of bipolar disorder. Um, Aside from the pharmacotherapy aspect of it, but it is very important to complement the medications given. So in conclusion, um, so World Bipolar Day, as I had mentioned, it aims to promote awareness and to give a platform for mental health advocacy. And we aim to educate the public, to support individuals living with bipolar disorder, and to reduce stigma. Um, so this is an opportunity for us to um, reflect on the measures that we can take as individuals, whether you are a individual, whether you know someone living with bipolar disorder, you're living with bipolar disorder, or you're a mental health care professional, whichever sector that you're in, just to reflect on how we can promote awareness of bipolar and to eradicate stigma. So thank you. I'll hand it over back to you, Dr. Mary. Thank you very much.
Thank you very much, Daisy. I think for me, it's just understanding there are different types of bipolar, and that in this country, we need data, but at the same time, the fact that whatever data we have shows that we as a country are affected by bipolar, our family members are affected, and we are not doing much to ensure that they live well. Thank you very much for this, and drawing our attention to the fact that there are ways in which we can cope with this condition. I will allow a question or two, because our participants have not used the Q&A. I've not seen a question there. So participants, please use Q&A. But for now, is there a participant with a particular question for Daisy? Is there anybody with a question? Please raise your hand. If we don't see a hand, we'll move on. Participants, please raise a hand if you have a comment or a question for Daisy. Joanna, I cannot see any raised hand. Can you see?
No.
Okay. So if there's no question for us, so apart from, let me just ask Daisy, apart from the Bungoma studies, are there ongoing studies in the country on bipolar specifically?
Yes, thank you.
Yeah.
Thank you for the question. There are various studies aside from this that have already been done, but there are also some that are being done currently. But you find out that most of them focus on mental health in general. So we are yet to see more that specifically focus on bipolar disorder. So that we can have a more in-depth analysis of some of the factors that are related to bipolar disorder, but they're definitely existing. Yeah.
Okay. Thank you very much. Any question from the participants? We are still open for that. Any comment for Daisy? Joanna can be able to see if there's a hand raised, right?
Yes.
Okay. We'll now, thank you so much, Daisy. I'm sure we'll get questions towards the end. I want to welcome Nicholas Osir. Maybe we'll start by you introducing yourself and then sharing your experience with bipolar. People will be interested to know when you realize you had this condition, how you live with it, how you're coping, and some of the challenges you faced as you cope with this condition. Karibu sana, Nicholas. Welcome.
Well, thank you so much for this opportunity. My name is Nicholas Odhiambo Sir. I am born and raised in Kisumu County. I was diagnosed in 2016. I'm living with the bipolar condition for the past 9 years. The first one was misdiagnosed because I was diagnosed with multiple mental illnesses. That is severe depression, schizoaffective disorder, clinical depression, anxiety, social anxiety, and then later on it was realized that bipolar 1. So it has not been an easy journey on my end. And also at some point during my first diagnosis, I attempted suicide thrice, but it wasn't successful. I now live positively with it, and I'm on medication. I use olanzapine in the morning, and then in the evening I use carbamazepine just to contain my condition. Currently, I'm working as a disability inclusion facilitator with an organization called Light for the World, but I'm attached to their partner called Practical Action on their resilient agriculture, working for young people project. I advise on matters of disability, and also I do mental health advocacy within my village where I come from here in Kisumu. I have formed a group of people whereby I teach them, and we create awareness on matters of mental health. It is a volunteering initiative, and we try and assist persons with psychosocial disability in maybe giving them some referral path on what to do whenever they have instances of mental health. So having mental health condition, remember in my family, I'm the only one who got it. So it wasn't an easy time for us as a family back then, because you find that it was something that was new, and it was rough on my end. But I asked myself, am I the only person who has got this condition within Kenya? So I began to try and Google within, search within the internet on maybe some organizations that support persons with mental health complications. I didn't get one here in Kenya. Most of them, I think back then, 2016, awareness was actually so much rampant within Europe. But I found out that there was a lady by the name Titawa Pula who was actually doing advocacy here in Kenya. So I contacted her through the website, and then I told her whatever I wanted, and she told me that she was not in the capacity to give me a job, because by then I thought that it was a job that was actually something that was that I really wanted. So she organized a way in which she placed me in a support group, whereby we are having a support group system right now here in Kenya called USP, Users and Survivors of Psychiatry Kenya. We actually support one another on matters of mental health, and we look at how we can cope. There are different coping mechanisms and how we live positively with this with this condition. So it is a group consisting of more than 300 persons living with different mental health related ailments. And I have learned to live positively, even though it is not easy on my end because on the side of medication. Here in Kenya, medications are quite expensive. You sometimes you have to, you have to wait. That is why many families with persons with psychosocial disabilities, they do abandon their loved ones because they can't actually afford the medication. Medications are very, very expensive on our end. So with bipolar, I have actually learned to know how to live with it on a daily life and avoid and I do look out on my triggers. I do know my triggers, so I try and avoid them. And together with some person with psychosocial disability, a lady called Maela, we actually made a film on mental health, creating awareness and trying to show people on how to live positively with mental health conditions and on how families actually intervene differently on matters mental health. The film is called What's Eating My Mind. It is viewed. It was aired in BBC Africa in their YouTube channel.
Thank you very much, Nicholas. When you talk about stigma, like what you've gone through, the assumptions people make, they can actually drive you to take certain actions that are detrimental to your health and to the lives of those people around you. Daisy, what kind of stigma situations have you seen among your colleagues?
Okay, thank you once again, Mary. So there's definitely a lot of stigma associated with mental health in Kenya. And we look at three types of stigma. There's self-stigma, there's social stigma, and there's systemic stigma. So if I could just explain, systemic stigma is, for instance, when you look at the structures that exist in both in the healthcare sector or in whichever sector that are somehow discriminating against people with mental illnesses or bipolar disorder. So, like for instance, a while ago, we did not have an insurance cover for mental illnesses, while other conditions are covered. So this is somehow discriminating against people with mental illnesses, among other forms of systemic stigma. There's also social stigma, which we are used to it, where people tend to discriminate against these people. They do not want to associate with them. They do not want to, they believe maybe they cannot function properly in the society in terms of school or work, or even in terms of interpersonal relationships, just because they have a mental illness. And then on most instances, because due to the systemic and the social stigma, the persons living with the mental illness or bipolar disorder, they tend to somehow withdraw from engaging with other people, engaging in social activities, or generally engaging in anything with the general public, because they fear being stigmatized. So at the end of it, they also stigmatize themselves. So in my line of work, I have definitely seen all these three types of stigma. And I think it is important for us to create awareness, especially on mental illnesses, to ensure that people understand that mental illness is just like any other illness. And it is not as a consequence of witchcraft or some of the myths and misconceptions that we have that affect our health-seeking behavior, so that we embrace these people. Even as people living with bipolar disorder, we come out and speak about it. We seek treatment and encourage other people to also seek treatment and to take care of their mental health. So awareness is one huge aspect of it. And I think we should work towards developing policies. I know in Kenya we are still working on that. It's a work in progress, but I feel we are somewhere compared to a few years back. But we need to have more of these policies that um, take care of the welfare of people living with mental illnesses or bipolar disorder, and also in terms of resource allocation. You find that both in the county and the national government, we almost never seem to allocate funds for any activities for mental health, and I believe it is paramount for us to do that and to advocate for that. And I think this day offers us an opportunity to advocate for this so that in the long run, we get to eradicate all these forms of stigma. Thank you.
Thank you so much, Daisy. Before you go, you reported about attempted suicide at 8.1%, I think, for men, and 5.48% for women. And also, Nicholas talked about his attempted suicide 3 times over time. What drives this from where you sit? Daisy.
Okay. Yes, thank you. So from the symptoms that we had for bipolar disorder, when you look at the one extremity, which is the depressive episode, it is often most likely associated with suicidal ideations and suicidal attempts. And in this depressive episode, the individual, they have symptoms like persistent sadness, they are hopeless, they withdraw from others. So in that moment of sadness, in that moment of hopelessness, they usually tend to have suicidal ideations. And also the fact that at times it is difficult to manage the illness. So somehow people usually tend to somehow resort to attempting suicide. But also in the manic episode, you find that these people are easily irritated during that episode. They are very impulsive. They may not clearly think through their decisions. And if they maybe they get into an argument, they might jump into conclusion and resort to attempting suicide. So it is the symptoms of bipolar disorder usually come out in that form. But aside from, we looked at some of the causes of bipolar disorder. So aside from the neurobiological changes and the genetics, there is also the psychosocial aspect of it. So you find that when someone experiences maybe stresses mentally or socially, it might affect their mental status, and it might trigger this episode. And because of these stressors, what one might not be able to manage the stress well, and they resort to attempting suicide. And you look at it, we find out that once someone has attempted suicide, the chances of them repeating an attempt is usually higher. So it is good just to look at some of the strategies that we can employ as individuals and even as caregivers of these people to identify these early warning signs, both in the body language or the verbal language, because some of the time they usually speak about it, or you can see that the behavior changes. They have started to withdraw from others. They are no longer enjoying what they used to do. They are no longer they have issues with their sleep, appetite, just behavior changes. So it is good to be vigilant on these signs, so that we ensure that we seek help in time before it reaches to that extent.
Robert Wamwangi, I've seen you make a few comments. Do you want to speak to some of these or respond? And then I've also seen Gertrude. Robert, can you hear me?
Hi, everyone.
Okay. Hi.
So I'm Gertrude Jepchishir, a medical psychologist, actually Daisy's classmate. So for bipolar mode disorder, I recently attended some conference in Cape Town, and there was need. Actually, the theme was there's need for psychologists or psychiatrists here in Kenya to adopt culturally validated psychometric tools. So most of these tools are based on the Western literature, but then there's need to validate them within the African and more so the Kenyan literature for it to be suitable when it comes to the accuracy of in diagnosis. Because also we've seen bipolar, for instance, the depressive episode of bipolar overlapping with things like MDD. I know we recently have a tool that has been introduced recently, but then we haven't validated the tool within the Kenyan context. So it's just a reminder to those in the clinical setup to try and validate the tool, more so through research and also publication.
Thank you very much, Robert.
I hope you can be able to hear me.
Yes, we can hear you now.
My first two comments, they are light comments. I won't take a lot of time on them. The first one was I was responding to what Nick had said, that he takes olanzapine in the morning, and I was a bit surprised about that. I think if one takes olanzapine in the morning or during the day, then one will be able to function during the day. The other comment was to do with olanzapine. I was reacting to his statement that the medication for mental health patients is quite expensive in Kenya. And I was saying that in the case of like olanzapine, about maybe 90%, this is just my estimate, that maybe about 90% of patients, they have to use generics because the original drug cost about 20,000. For 1 month, cost about 20,000, which is not easily affordable for somebody who might not be having an medical insurance cover. Now, I had a question for Daisy concerning the issue of handling stigma, especially when we're dealing with integrating somebody who has had an episode, a patient who has had an episode, say, for example, going out in the streets, maybe removing clothes in the streets or in public, or maybe collecting garbage in the streets, or even having attempted suicide. How, as professionals, my question is, as professionals, how do you go about integrating the person back into the society and minimizing on stigma, both self-stigmatization and as well as social stigma, both from the point of view of the patient as well as, say, the family members or the society at large? That's all.
Robert, that's a very good question. And thank you so much, Gertrude, for highlighting some of the lessons we've learned and the need to adapt the tools that are already in the field. I think the issue of stigma is huge, and the situation, Robert, you've mentioned, your brother or sister has been involved in this. In my community, then they stigmatize not only the patient, they stigmatize the entire family. How do we manage that in the long term? And I guess this is why we are having these webinars, so that we begin to tell people this is a condition, and we begin to build that awareness, to build that understanding at the community level, so that when your parent or your brother or your child has gone over this period, the stigma doesn't throw them back into the valley again. I'll let Daisy respond to this and then go back to Nicholas because of time. So that, Daisy, do you want to give a quick response, and then we'll finish with Nicholas? Over to you, Daisy.
Thank you. That's a nice question. Like you mentioned, we have a long way to go in terms of eliminating stigma. But from whichever level that you are in, I believe everyone is in a position to work towards eradicating stigma in whichever level you are, whether it is as an individual, as a caretaker, if you know someone, if you're a mental healthcare professional, if you're in leadership. Both of us have a critical role in eradicating stigma. But I believe one critical aspect, even before the stigma aspect of it, like you mentioned, educating the public so that they can understand that this is just an illness like any other. And this will somehow stimulate even these people to seek treatment, to somehow prevent the illness from having these episodes, so that someone manages to manage the illness, and it might not get to a point where they might remove their clothes, they might not be able to function in the society, or when this illness becomes a chronic case. So if we look at the prevention aspect of it, it will be very important. And also, even if the person experiences these episodes, we encourage them to seek treatment. And even whichever level, whether it is at home, whether it's in the workplace, I think right now it is an opportunity even for the workplace to support these people who are living with mental illnesses, even in terms of prevention, in terms of treatment, and even after the person has stabilized and they are now supposed to be reintegrated back into the society, both in the workplace, and even at home in the community. We have programs for them to be taken through that integration process, so that there's no discrimination after that. We are able to have accommodations for them if we are in a position to do so, and also just support them in different ways that we can. Yeah.
Thank you. Osir, a final comment from you?
Yes, at first it wasn't easy on my end because I used to sleep a lot back then, but right now I can function well and it works for me. I don't get problem using muscle. But with doctor's review, each and every time a dosage I've gone down a bit. Yes, so that's what I would like to tell Robert. And for any person who is actually undergoing through a mental health challenge, my advice would be seek medical attention and just know your triggers very well and work on it. Thank you so much.
Thank you very much. Know your triggers, and people who live around you also are observant, and you get medical care as soon as is possible. Thank you so much, Daisy. Thank you so much, Nicholas. I want to thank all the participants. I also want to thank Joanne and the AHD team and the Bipolar Warriors team for this webinar. We will continue talking, we'll continue sharing, we'll continue creating awareness on mental health in this country so that we take care of our brothers and sisters who have to deal with this on a daily basis. Thank you very much and have a fantastic evening. Bye-bye. Thank you.